Hello, everyone, and thank you so much for joining us today. Welcome to the ATS Thoracic Oncology Assembly webinar, exploring the natural history, clinical outcomes, and management of subsolid nodules. I'm your moderator today. My name is Yeon Kim. I'm an assistant professor of medicine at Seoul National University Hospital in South Korea, and I'm very delighted to be joined by our co-moderator, Dr. Roger Kim, who is the chair of the ATS TOA Early Career Professionals Working Group and assistant professor of medicine at the University of Pennsylvania. So what we're going to do today is we'll be discussing topics that many of us have likely encountered in our clinical practice while taking care of our patients with pulmonary subsolid nodules. We will begin with a brief but comprehensive introduction to the evaluation and management of subsolid nodules to help us set the stage for the conversation, and then we will move directly into a multidisciplinary discussion with our expert panelists. Our goal is to come together to consolidate what we know right now and explore the path forward. We also truly want this webinar to be interactive and engaging, and we'd love to hear all from you. So please feel free to share your thoughts, questions, or clinical experiences in the chat box at any time. And Roger and I will do our best to incorporate as many of your insights as possible throughout the session. Before we begin, I just wanted to give a quick reminder that today's live event will be recorded and made available on the ATS Thoracic Oncology Assembly website for future viewing. With that, I'm truly delighted and excited to introduce our expert panelists who will bring a wealth of knowledge and experience to today's discussion. First, we have Dr. Andrew Haas, Director of the Section of Interventional Pulmonology and Thoracic Oncology, Director of Bronchoscopy, and Professor of Medicine at the University of Pennsylvania. He is a highly respected interventional pulmonologist with deep expertise in this area. So welcome, Dr. Haas. We are also very honored to be joined by Dr. Gavitt Woodard, Assistant Professor of Surgery at the Yale School of Medicine. She is an amazing practicing thoracic surgeon with a dedicated clinical and research focus on pulmonary subsolid nodules and adenocarcinoma spectrum lesions. Welcome, Dr. Woodard.
Thanks for having me.
Okay, last but not least, we have Dr. Mark Hammer, who is a wonderful radiologist and an associate professor of radiology at Harvard Medical School and director of the Thoracic Radiology Fellowship Program at Brigham and Women's Hospital. Thank you so much for joining us today, Dr. Hammer.
Thank you.
Okay, so before we dive into the discussion, Roger will start off with a high-level overview of some key considerations in the evaluation and management of subsolid nodules. So, Roger, would you like to take it from here?
Thanks so much, Yeon, and welcome to all of our expert panelists. So I'm just going to go through some very kind of basic introductory stuff to frame some of our discussion today. So first, to start off, what are we talking about here? So subsolid nodules, they're also referred to as, part solid. Sometimes you might hear ground glass, non-solid. And so, just to kind of reframe what some of the terminology that you might hear some of our panelists talk about today. The term subsolid nodules really just refers to anything that is less dense than a solid nodule. And I've put together this kind of crude depiction of, ranging for anything from, non-solid on the left side of the screen here, which is also referred to as ground glass sometimes. And as the solid kind of component or density of particular areas within the lesion increase, we sometimes then refer to it as a part solid lesion and refer to the most dense part of it as the solid component. Subsolid nodules comprise approximately, depending on which study you're looking at, around 10% of all screen or incidentally detected pulmonary nodules. And among those that stick around on repeat imaging, the majority of them, anywhere between 30 and 80% of them, represent adenocarcinoma spectrum disease, which we'll get to on subsequent slides. While most subsolid nodules do follow an indolent kind of natural history, there has been some data that suggests that anywhere between 10 and 50% of them actually do grow and can progress to invasive disease. So the kind of big conundrum that exists in the decision making when it comes to deciding what to do with these subsolid nodules is this question of overdiagnosis versus early diagnosis. So, like we talked about, a lot of these subsolid nodules follow a pretty indolent course. And so if you were to, let's say, resect it or treat it outright when you first detect them, the obvious benefit would be a potential cure of early stage lung cancer, favoring, of course, earlier diagnosis, earlier stage disease. We all know that the survival benefit's better. However, if that same lesion would have never actually affected the patient's longevity and would have stayed indolent their entire lifetimes, well, then now you're potentially unnecessarily exposing patients to the risks of either a biopsy or a surgery. And so really that's kind of this seesaw or tug of war, so to speak, that we have to think about whenever we think about management of subsolid nodules. The important thing, and I suspect you'll probably hear from some of our panelists today, bring some of these up. It's important to remember that the guidelines do not align with how to manage subsolid nodules. So this is just a kind of a brief summary that I put together of some of the various guidelines that do exist, ranging from the Fleischner guidelines, National Comprehensive Cancer Network guidelines, American Association for Thoracic Surgery, and then LungRads for screen-detected subsolid nodules. And you can see, I'm not going to go through them all here, that they all vary slightly as far as what constitutes, a concerning size or a concerning size of the part solid component, how long you should even, continue to follow these subsolid nodules for if you don't intervene on them, at what intervals you should intervene or you should, surveil them with imaging, and then of course how you should go about managing them when you do decide to do something more invasive. Should it be a PET scan? Should it be a biopsy? Should it be a surgical resection or a surgical biopsy? And so these are some of the kind of things that we're going to hopefully get into today. But with that, I'm going to stop sharing my screen and we're going to dive into some of our questions here. So without further ado, first question we have for our expert panelists is, like we talked about, there's significant heterogeneity described in the literature regarding the natural history and clinical outcomes of subsolid nodules. Generally, there is guideline consensus to obtain, at least initially, a short-term interval image to confirm that the subsolid nodule persists as a first step along the diagnostic pathway. However, among persistent subsolid nodules, clinical practice is largely non-standardized, as we reviewed. And so the question for our panelists is, what has your clinical experience been with managing patients with subsolid nodules in your kind of personal clinical practice? And for this first question, we'll start off with Dr. Haas.
Thanks, Roger. Great questions. And, I think at least that initial evaluation that I do when I see a patient with the ground glass nodule or subsolid nodule, somewhat dependent on size. So if it's a very small lesion, 6 millimeters or less, I might get a scan at 6 to 9 month time frame to see if that has persisted at that interval of time. If it's a larger nodule, usually greater than 6 millimeters or so, I might get a 3-month CT scan. Once I've demonstrated its persistence at that interval, which, in the majority of times, I think it probably does persist. Some of them do resolve, but the majority of them do persist. Then, it extends out, again, depending on size, to that 6 to 12 month time frame. And then it evolves over time from there, not necessarily following guideline specific recommendations as much as it is a shared decision with the patient and their anxiety level, right? Some patients just can't live with the anxiety of this evolution I often talk to them about, from atypical alveolar hyperplasia to carcinoma in situ to minimally invasive and so on. The concept of not doing something about I might have a cancer they just can't live with. And so I tailor somewhat the timing of that based on their personal anxiety and coping skills with the uncertainty of that nodule that's there.
I would agree with that. I think, we all have slightly different ways of managing, though what was just described, I would totally agree with, and I think is very reasonable. So we all have our own way of managing. And then on top of that, the individual patient's preference adds this entirely new dimension of how comfortable are they living with something, where I can just say, if we were to take this out with surgery, path is probably going to show adenocarcinoma. Some patients are extremely uncomfortable living with that and just want it out. and would prefer to undergo surgery just rather than sit for another 3 months with a possible lung cancer inside of them. Other people are more adverse to having things done and are happy to hear that we think this can safely be observed. So I think a lot of patient preference and the way that you have the conversation with them can change how things are managed.
Mark, as the lone thoracic radiologist on the call, any insights you'd like to share?
Sure. Yeah, absolutely. I agree with, I didn't have any specific disagreements, so I was just gonna let it slide. I mean, obviously I don't talk with the patients directly. I do think that the way our reports are worded also is important though, because the more we say adenocarcinoma spectrum, I think the more the patients get anxious about it. But yeah, I mean, it is, so to Dr. Haas' point, right? So the studies show about a quarter of parsal and ground glass nodules detected at a baseline scan are going to be inflammatory. Probably going to be a higher fraction if they develop new over time. And yeah, I mean, generally these are slow growing. So, you know, while you know, I will generally make the guideline recommendations of 6 months or whatever it says for the initial follow-up. In my experience, except for ones that resolve, things almost never change. And we're really talking about changes that occur over the course of years in these patients. And I guess, you know, we can get to, well, yeah, I guess I'll kind of stop there.
Okay, that was a great, oh yeah. Do you
Can I
want to add
interject?
some more?
Sorry, I know I'm not the moderator, but just to interject how things evolve in my 20 years of this experience now is that 20 years ago, one, patients didn't have access to their reports. And also adenocarcinoma spectrum lesion terminology didn't even exist. And so both of those factors now, patients having access to the reports immediately, oftentimes before we have access to them, as well as this terminology that certainly has relevance, but how that patients have no idea how to incorporate that relevance into the reality of what that lesion may represent is just completely beyond them.
Feel like I see patients in clinic for the first time and I have to talk them off a ledge that no, don't worry. You know, this is not some urgent lung cancer that's going to kill you. And it's a, you know, I use flavors. It's totally, you know, it's a totally different flavor of lung cancer. And so, you know, you have to first explain to them that they're really not in the same boat as the lung cancer that they typically think of when they think of lung cancer.
Great. That was a really great start off for our next discussion. So I just want to switch gear just a little bit about growth of the subsolid nodules, because that when we see the growth, that's when we think about, oh, do we have to do more or do we have to intervene? So one area of the variability among clinical guidelines right now is defining what is actually clinically significant growth, not just simple the radiology growth, right? What do you consider to be a clinically significant growth in terms of increase of the overall size or development of a new solid component, or increase of the size of the solid component, or actually the rate, the speed of the growth? And plus, what imaging-based criteria should be prioritized when defining growth and progression for subsolid nodules? So with that question, Dr. Woodard, do you want to start?
Sure. I mean, again, this is a complicated question because we're lumping a lot of things into one kind of growth criteria. I frequently use a cutoff of 2 millimeters a year, but that is kind of dependent on what size you're talking about, because 2 millimeters a year is a different percent change for a very small nodule than a larger one. And I agree with the comment earlier that often we're watching these over many years. And so it really is getting a sense over time of, is this changing dramatically? You can talk about the ground glass portion, which I start to think that we should intervene once they hit about 2 centimeters is my general practice. And then for the solid component of these, when it starts to get to be more than a few millimeters, to me, surgical resection becomes a little bit inevitable at that point, and we customize our management when there are multiple nodules. But if we're just talking about a single nodule, once the solid component hits a few millimeters, I start to think, well, eventually we're getting to surgery, and it doesn't have to be urgent and it doesn't have to be now, but I think that you are headed this direction. But again, things move really slowly. So a millimeter of growth over 10 years. We have patients who have them followed for that long. You're talking about a centimeter over 10 years. That's probably something you can keep watching, even though it gets bigger and bigger and bigger. But there's just a huge spectrum in the behavior and the different size cutoffs and growth cutoffs that you can think of.
Yeah, I think, oh, go ahead.
Good, Mark.
Oh, okay. I think that one thing that Dr. Woodard mentioned, which maybe we'll get into discussing more later, is the presence of multiple subsolid nodules. Actually, I don't have a statistic offhand, but a lot of patients we see who have subsolid nodules have many of them, or at least more than one of them. And in those cases, the management is more tailored, right? Because you can't start chopping off too much lung. And so then I think it's a lot more conservative management, following people until they grow. Let's say you had a patient who had only one nodule, you could, I think, make the argument, well, let's just take that one out. It's either now or in 10 years we're taking it out, so may as well just do it, right? But if you have multiple, then you have to decide which ones you're taking out. So those are really the following is a lot more important. And I guess I may as well just make my comments about how I assess growth. I think a lot of, what the ground glass component represents is a bit controversial, or at least maybe controversial isn't the best word, but a bit unclear. It varies from patient to patient. The ground glass component tends to correlate with the lipidic or non-invasive components pathologically, but it's not by any means an absolute one-to-one correlation. And you will find invasive components or invasive percentages, at least, in the ground glass components. That being said, on imaging, and in terms of the sort of biological behavior of the tumor, it's really the solid component that's mostly associated with the aggressive behavior. And so I feel like I'm not super concerned about the ground glass component growing, and I'm a lot more concerned about either an increase in density, overall increase in density in these lesions, and we can discuss that more a bit, because it doesn't quite fit into the ground glass part solid dichotomy that we often talk about with these lesions. And then, of course, growth and development of a true solid component. And again, if you look at the guidelines, people are talking about 5 to 6 millimeter range as to when you should start thinking about intervening. But as Dr. Woodard pointed out, smaller solid components may still be a trigger for intervention. Again, not urgent, but and again, it depends on the number of lesions. If you have one nodule and it develops a 1 millimeter, 2 millimeter solid component, that may be a reasonable trigger, versus 5 or 6 nodules. Each of them has a 2 to 3 millimeter solid component, and you're kind of waiting till one of them ekes out slightly ahead of the others. Anyway, I'll let Dr. Haas continue.
Yeah, I think the couple important points to make for those that kind of evaluate these, for those listening in, is oftentimes we'll even see on our reports here, at a very experienced thoracic radiology program, is the reports only go back to the last scan. And in these types of lesions, you have to go to the first scan. If you're lucky, right, you have the luxury of having several years of scan, you have to go to the first scan versus the most recent scan, because that evolution can be so slow. And then I also think it's important to look at it in all three planes, so axial, sagittal, and coronal, because you sometimes will see growth in differential planes that you won't see if you just look at the axial, which is, I think, what a lot of people just look at the axials. So those are two, I think, important points. And then specifically the growth rate, I don't want to recapitulate what everyone said, which again, they tend to be very slow. Our general threshold is for considering intervention is similar to what Mark mentioned. So around the 5 to 6 millimeter solid component, or a ground glass component getting closer to 3 centimeters is what most of our surgeons will say, I think it's probably time to act now. And that's how I always explain it to patients. What we're looking for over time is larger ground glass and or solid components developing, not necessarily one or the other. The solid components, as has been mentioned, is certainly the one we're more concerned about. But that radiopathologic correlation, I think, is not precise by any means that ground glass means it's not invasive, because I think we've all seen that can be the case.
Yeah. I had one comment about the multiple nodules, and I know we're going to talk more about this later, but I think that this becomes the key discussion point. And we did a big review of our Yale patients here with this and presented it at World Lung and American College of Surgeons. And so we had, in our population here, we had like around 50%, 49% who had multiple nodules in this group. So it's really common and, you know, just as likely to have more nodules form in the future. And among our patients who had surgical resections for semi-solid nodules, 30% of those patients went on to develop another lung cancer that required treatment in the next 5 years. And so it's really the challenge of lung preservation and how to deal with, you know, what you don't know, what's coming in the future. So do you overreact to something small at the expense of resecting a lot of otherwise healthy lung tissue? And I feel like that's the challenge. A single lesion, or, you know, I'm a surgeon, but I think our surgeries are pretty safe. And so that's not so hard to deal with, even if we're kind of over treating on the individual patient level with operating on these. The real struggle is when you have multiple nodules and knowing when to pull the trigger and not wanting to over treat something that really isn't a threat to someone's mortality.
Man, this discussion has been awesome. And yes, we will definitely get to multiple subsolid nodules down the pike here. So I'm really glad that that we're already kind of bringing that up. But I want to, before we get there, I want to kind of back up a little bit. And I think everyone's sort of been alluding to at this point, you know, as far as like this clinical significant growth or clinically significant growth that we were just discussing. But the next kind of step in the algorithm after that is kind of to decide what to do once you have determined that it is clinically significant growth. So let me just be a little bit more specific. So, you know, when we traditionally think about pulmonary nodule management in general, we're, you know, most of the time talking about solid lesions, or at least, you know, mainly, you know, part solid lesions. And where the question really then becomes, and this, I'm curious to hear what Gavitt has to say, it kind of, in my experience, is dependent on the surgeon, whether or not they would want a confirmatory biopsy first to prove, in fact, that it is, let's say, an invasive adenocarcinoma as opposed to, you know, something different, before actually going ahead and committing the patient to a surgical resection. And so the question for all of our panelists is, you know, in this day and age, obviously myself and Andy being interventional pulmonologists, we're a little bit biased, but in this day and age of having the ability to do relatively safe, you know, peripheral navigational advanced bronchoscopy, you know, with the ability to do cryobiopsies and things like that to try to increase our kind of surface area that we're actually able to biopsy, so to speak, as opposed to some of the historical data that exists from, let's say, 10, 20 years ago that suggested that a bronchoscopic biopsy for a subsolid nodule might be in the 30% range. We would like to think, although the data isn't quite mature enough, we'd like to think that, you know, our diagnostic yield, even for these types of lesions, has gotten better over the years. And so I'm really curious to hear what all of our panelists' current kind of practice patterns are with regard to whether a biopsy is necessary, number one, and then kind of number two, what type of biopsy to pursue prior to, you know, pursuing definitive treatment with either SBRT or surgical resection. And for this one, we'll start with Dr. Hammer.
Sure. Well, yeah, thanks for the question. I also do CT-guided lung biopsies, so I can answer kind of with both of those hats. But in my opinion, you know, assuming, let's say we have a context where the nodule, a subsolid nodule, is persistent, and certainly in the case where it's growing, I don't think a biopsy is really helpful from a diagnostic standpoint. We certainly do biopsy these lesions on occasion. Usually, there's two contexts which are kind of related. One is that the patient is reluctant somehow to pursue definitive treatment before having tissue diagnosis. And the second is that the patient is not eligible for surgical treatment, and therefore it would be radiation therapy. And so they would want a tissue diagnosis before proceeding. But if a patient is eligible for surgery, then I don't think there's a diagnostic dilemma here. And just to touch on, you know, biopsy yield, similarly to, I think, what you alluded to, Roger, you know, there is some data from, I don't know how old, many years ago, saying that, yeah, there's reduced yield for CT-guided biopsies in subsolid nodules. And I will say that, you know, perhaps, you know, size for size, the yield is probably going to be a little bit lower on the subsolid nodules, especially small, pure ground glass nodules, which can be tricky because if you get hemorrhage in the lung, then that will obscure the nodule completely, and then you can't be sure if you're still in it. But that being said, you know, our yields are I'm sure like over 90%, if not over 95% diagnostic yield in getting a tissue diagnosis on these lesions. The only caveat is that we won't know the invasiveness. So usually the pathology will say something like, adenocarcinoma at least in situ. And so then it won't tell you like how invasive it is. Again, that doesn't necessarily drive your management, but just be aware that, your answer isn't going to tell you the actual T stage of the lesion.
So I'll say that Sir William Osler had a famous quote saying, medicine is the science of uncertainty, but the art of probability. And so, in these cases, and I'm probably the pariah of both interventional pulmonary and the technology companies, I think a biopsy has virtually no role. If you have a lesion that's persisting, you have a lesion that's ground glass and or developing solid components, my pretest probability this is cancer is so high, I don't understand why we do biopsies, period, quite frankly. And so it's that shared decision at that point with the patient. Are we going to continue to surveil because we don't think that this is at a point where it has a behavior to intervene? Are you going to operate? Or maybe a little bit different than your practice, Mark, we do a lot of empiric radiation for these nodules rather than trying to biopsy them. Because again, our pretest probability is so high that this is what it is. Why put the patient through a procedure, the cost, if this is what we're going to end up doing anyway, if we don't believe our biopsy or don't get the biopsy? So I'm not sure I see a ton of role for biopsies with these lesions. If you have documentation of persistence and evolution, it's different, right? If it's smaller or it's not changing in size, whatever. So that would be my perspective.
Yeah, I agree with what's been said. I know our audience is a lot of pulmonologists. And so I'll preface this by saying for pretty much every solid nodule I see that I think is a cancer, that patient is getting an ion bronch and an EBUS because we have a very strong interventional pulmonology team that gets people in right away. And so that's my fastest way of getting a biopsy, and then I get the EBUS tacked onto it. So I love that procedure. I never send these patients for biopsies. I don't get an EBUS on them. I explain it to them in this context. I say, this is concerning on imaging, and I think I know what this is, and we've usually had a lot of conversations before we get to this point. And I say, if I send you for a biopsy, and the biopsy comes back atypical pneumocytes, or, something indeterminate, that doesn't change anything about what I'm seeing in your imaging that I find concerning, and I think that you need a treatment, either way. So nothing that's coming back on this biopsy is going to change the way that I think about your nodule, and that usually is pretty convincing for them. But to something that Mark said, I totally agree. The reason why sometimes I do send people for biopsies is when the patient is a little reluctant or slow to think they need surgery, or they don't really believe it's cancer. And I say, okay, fine, let's go get a biopsy. And usually we get some sort of cancer diagnosis back. I'm trying to think, I'm sure at some point they've found nothing, and then you're back having the same conversation. But I just basically tell them, the imaging is what it is. It's been there for years. It's growing. We need to address this. And usually patients are pretty amenable to skipping a biopsy in those situations.
Okay, that was a great discussion. I just wanted to ask one thing that we should be thinking about, that to actually accurately diagnose the adenocarcinoma spectrum lesion, to see the invasion of the lesion, we have to get the whole lesion, right? So yes, we have to have the entire lesion and see if there's invasion in that lesion. So there is question about the role of non-surgical biopsy in subsolid nodules too. Great. That was a great discussion. I will move on to our next question about, so we know that subsolid nodules are very indolent and they rarely go crazy and develop like rapid growth and do so, but there are some uncertainties, right? So many efforts have been made to develop other predictors of those aggressive transformation or growth, or will this be a clinically significant disease? So there have been many radiomic-based studies and a few like tissue-based or blood-based biomarkers, among others. And what are your thoughts on the current state of the subsolid nodule biomarkers and what the future might hold for this technology in evaluating the risk stratification for subsolid nodules? And for this question, Dr. Haas, do you want to start off?
Sure. Yeah, I think while they may, at least to my understanding currently of the technology that we have for biomarkers, they still don't give us a sense of aggressiveness of the disease, right? They tell us cancer or no cancer. And really what we need to know is the aggressiveness of the disease. What is the biology? And we don't have that from any biomarkers, either radiomics or blood-based biomarkers, tissue-based biomarkers. So in that regard, I'm not sure that they change the conversation that you're having with the patient about these nodules. And so I think that's potentially different, right, in a screening population where you have a nodule where you want to use that information to decide how you're going to proceed. But this is a different population and a different type of nodules. So I would love to see the development of biomarkers, radiomic-based markers that can tell us when characteristics are changing, that now is the time to act. So, you know, my 55-year-old patient who can get a biomarker that says it's fine versus my 85-year-old patient where we can, you know, do nothing. So I think that's what I would like to see that to my knowledge, I don't think we have.
I would say the state of biomarkers is there's nothing really that's being used clinically. And so it's definitely an important area of research, especially given how common these are, and they're becoming more common. The better our imaging gets, and the more patients, especially non-smokers or light smokers who end up getting screened for lung cancer, this just is a ballooning problem. And so unless we find better ways to identify which are the more concerning semi-solid nodules, I agree completely with the point, nodule versus cancer. We know these are all adenocarcinoma, or the majority of them are. So how to differentiate concerning semi-solid nodules from really indolent ones that can be ignored.
Yeah, I think the reality is, right, that these are evolving over time. So at any one point, it may not be an aggressive lesion, and presumably it is going to acquire more mutations and become more aggressive over time. And so we almost never see them, you know, as some of the go crazy. They're generally slow growing. I think there is an inflection point that occurs in some of these lesions, usually when they get larger. And in my experience, typically what has happened in those cases is that the patient has been in some fashion lost to follow-up. Either the lesion was not described as concerning in the first place, or the patient just left and, you know, hasn't, and then finally comes back, and it's been a long gap in time. And then we see that, oh yeah, that thing that was ground glass, or maybe had a small solid component, now the solid component is much, much larger, and it's 5 years later. But, you know, nodules that are undergoing constant surveillance, that is an exceedingly rare phenomenon. And I was recently reading, there's some data out of Italy from their lung cancer screening trial where they specifically focused on subsolid nodules, and essentially every single one that eventually got diagnosed with cancer was either stage 0 or 1. The patients had other cancers that developed in the interim while they were screening them that were higher stage from solid nodules, but the subsolid nodules, as they were constantly surveilling them, basically, you know, did either nothing or, you know, were early cancers.
We did this really, I mentioned this earlier, we did this very detailed study of our Yale patient cohort. And so the chance of dying from your semi-solid nodule was like 2%. The chance that while we were watching this nodule, that you develop a new other cancer and die of that other cancer was 9 times greater than the risk that this semi-solid nodule had anything to do with future mortality.
What an excellent potential segue into our next question. And, you know, I guess just to maybe also add on to some of the things that Mark and Gavitt just brought up, I think that really just highlights the importance of, if you are going to take the less invasive, you know, surveillance route with these subsolid nodules, the key thing is adherence, making sure that the patients actually do come back to get their follow-up scans, specifically because of what Mark and Gavitt just brought up, that it may not actually be the subsolid nodule itself that is the issue, but we know that the host in whom the subsolid nodule has developed in is at risk of developing other potential cancers that actually may be more of a threat to their longevity, and you know, have a higher risk of metastasis and invasive disease. So excellent points there. But I guess let's, we've been alluding to it now for the past, you know, 30 minutes, but I think it's time to ask the question. And you know, so I'll just give a little bit of the preamble that we've already kind of talked about a little bit. But, you know, these subsolid nodules almost never, you know, I shouldn't say never, but almost never present alone in isolation. They usually are accompanied, as Gavitt just mentioned, either with a separate, concerning spiculated solid lesion, or more commonly in conjunction with many other, or at least one other subsolid lesion, either synchronously or metasynchronously during follow-up. And, traditionally, this has been seen, at least based on epidemiologic studies, classically in young Asian women from, Far East Asia, as far as ethnicity goes, but can certainly be seen in other populations as well. And this really is truly the bane of a lot of our existences, just to put it bluntly, because it can be extremely challenging to know what to do with these different nodules. I think just to summarize the guidelines briefly, most of the guidelines would say, you should choose the quote unquote scariest looking one, and how that's defined, I think, varies. But I think Mark alluded to that earlier, but you're supposed to choose the scariest looking one and sort of focus on that one while sort of also keeping the other ones in the background. But at the end of the day, I was chatting with a thoracic surgery colleague of mine. At the end of the day, you can end up playing this game of whack-a-mole, where you try to take out one and then another one gets bigger, and then at the end of the day, you run out of lung to resect. And so this ends up being a really tricky issue. And so I'd really love to hear everyone's thoughts on how you personally deal with this issue. And for this one, we'll start with Gavitt.
Oh, thank you. Yeah, I think this is where the discussion is interesting, because that's when you actually have to make some more important or trickier decisions about who to treat. So agree, you focus on the leader of the pack or the most dominant lesion. And I would say I typically I let these get a little bit bigger. I let them get a little bit more concerning than I would someone with a single nodule before recommending treatment. Other things that come into account, certainly for us as surgeons, is whether this is central and it's lobectomy requiring, or if this is peripheral and it can be addressed with something sublobar, either a wedge, which I think is appropriate for these, or a segmentectomy. I also take into account which side things are on. Someone who has 3 semi-solid nodules, but they happen to all fall on the right side. Okay, well, I can go clear all these out at the same time, hopefully with wedges. We're not doing 3 lobes on the right. But so, as much lung preserving surgery as possible, I think, is what the really important approach is. And more central lesions, those that would require a lobectomy, I have a much higher threshold for recommending resection, for the reasons that we've all discussed already, just that this patient is prone to forming another one. You don't know if 1 year later they're going to get an actual, real big bad lung cancer in a different lobe, and now you've taken away, a lot of lung parenchyma if you did a right lower lobe lobectomy on them. So it does become kind of a more nuanced conversation at that point. And so I think, higher thresholds and thinking about what is peripheral and can be wedged versus what is central. Or do you just want to, radiate the more central ones, which I don't love doing, because I think then they're harder to follow over time. But that is our general management.
Yeah, Roger, to your point about the frequency of this, I actually had a clinic today, and I had 2 new patients, both of which had multifocal adenocarcinoma, or multifocal GGOs, a few with very small solid components. So in my practice every week, I have 3 clinic days a week, I probably see 5 to 10 patients with either a GGO or subsolid or multiple ones. So this is a huge part of practice these days. And as I said, very different from 20 years ago when I started. So, to come back to the topic at hand, I don't know they have much more to say than Gavitt, because really that's kind of it, right? I mean, it's a multidisciplinary discussion with the patient and the surgeon and radiation oncology, what's going to be the best one to approach, the most solid one, the one that's changing behavior. And you have to factor all those things into it, as well as patient motivation and age and comorbidities. So, I'm sure, Gavitt, if somebody had a prior cabbage or, some other thoracic surgery,
any other risk factor,
pleural, right? All those things kind of factor into that decision process about whether surgery is going to be the best approach, or whether they're going to need radiation or continue to surveil them, because it hasn't changed that much yet until you're going to, go ahead and move forward with treatment. So it is very challenging. I think that the most challenging part is the discussions with the patient, and really doing that in a fashion that they understand it, that this is what we think is the best approach, but we're probably going to have to deal with things in the future, and walking them through that and understanding it in a fashion that I think they can follow in a logical way and in a compassionate, empathic way, really, in many ways. So, because I'm sure Gavitt doesn't use the terminology of we're playing whack-a-mole, so with our patients. So anyway, I'll defer to you, Mark, if you have any other thoughts.
Yeah, I mean, I agree with everyone said. I don't have anything specific to add on those points, but I think there's a few other points sort of epidemiologically / other diagnoses that we should kind of think about or keep in mind. Firstly, right, as Roger mentioned, classically is described in Asian, women of Asian origin, but we're seeing this more and more in women of other origins, particularly women, in the non-smoking. Smokers, either gender for sure, but non-smoking in women of kind of any ethnicity, we're seeing it more and more. And unclear if that's because we're scanning literally everybody under the sun, or if there's some other, epidemiology that's changing. There's a very tiny fraction of these patients who have a genetic predisposition, like, for example, a germline EGFR mutation. That's exceedingly rare, but it does occur. So something to just keep in the back of your mind. The other thing to keep in the back of your mind is metastatic disease. So on occasion, we will see situations where there's a dominant mass. Usually it's this sort of consolidative appearing adenocarcinoma, and there are multiple ground glass nodules either in another lobe or the other lung. And those are actually metastases from, it's usually mucinous histology, adenocarcinoma. And so it's something just to be aware of. We're all right now talking about the situation where we've got a couple, even maybe more than a couple ground glass nodules, usually upper lobe predominant. They usually all look a little bit different, right? Pure ground glass here, slightly larger pure ground glass, maybe one of the tiny solid component. They're all kind of different looking and they're all slow growing. Whereas the metastatic scenario, again, usually it's mucinous adenocarcinoma. You've got a dominant lesion and then a bunch of other things which look a bit too similar. And if you follow them over time, they're going to grow more rapidly. And those are metastatic, not separate primary. So just something to be aware of in the differential diagnosis when you approach one of these patients.
Yeah, Mark, just a point on your epidemiology, just to the two patients I saw today. One was a Northern European Caucasian female, and the other was a Russian gentleman in the fallout from Chernobyl. So probably was, I suspect, non-smoker. I suspect was his etiology driving these lesions.
Okay, that was a great discussion. I just want to switch our gears just a little bit about managing and surveilling these subsolid nodules. So one of the key questions is that how long and how often do we have to follow up these lesions, especially those which were very stable for like several years, and we think that this is going to be indolent, but we are not really sure about whether safely the surveillance could be discontinued, right? So the Fleshner guidelines recommend at least 5 years of follow-up to confirm subsolid nodule stability, but beyond that period, we don't actually have much data regarding their. We know that they're indolent, but we don't have like much high-level evidence regarding their natural history and when is the safe moment to discontinue the surveillance regarding the patient's like competing cause of death, age, radiation exposure, and things like that. So my question is like, what do you think is the optimal follow-up duration of these long, stable subsolid nodules, like 5 years, 10 years, or etc.? And yeah, what are your thoughts about this? And Dr. Hammer, would you like to start off?
Sure. Yeah, this is something I struggle with a lot, and I'm not even actually talking to the patient, but I still have to struggle in terms of what I say in my report. I don't know the answer to that question. There was a recent study just published in Chest, I think very recently, where they looked at, these were ground glass nodules, pure ground glass nodules that were stable for 10 years, and then they surveilled them even further up, maybe up to 15 years, and they said, well, 4% of the nodules that were stable for 10 years grew after the 10 years, right? So these are indolent. They are going to slowly grow, which makes sense because we think they are sort of precancerous / early cancerous lesions. So I think, and you alluded to this, right? There's question of competing challenges, right? Competing risk for the patient. Patient has a competing risk of death of other causes. So if they're elderly, have other comorbidities, et cetera, right? Probably we don't have to worry about these. A young patient, okay, yes, they have many more years in which to develop a solid component, develop an invasive lesion, develop metastatic disease even. At the same time, of course, we're going to be scanning them and therefore exposing them to radiation. Now, I will tell you that our current CT scan technology has really dropped the radiation dose for these lesions, and we're doing ours low dose. I don't actually know if everywhere in the community is doing low dose scans for nodule follow-up, but we certainly are. And this is quite a low dose. It's not, it's higher than a chest X-ray, but still pretty low dose. But it's not zero, right? And if you're talking about a relatively younger patient who is more radiosensitive, who's going to be imaged for decades potentially to come, that is an issue. And so we can talk about if there's alternative strategies. But I think that all of these are concerning. That being said, my thoughts on this are to not really stop surveilling these patients, excepting the 80-something-year-old patient with comorbidities who is, probably going to die of something else.
I guess I would reflect the same thing. It's very age dependent. And so the elderly patient with the comorbidities, the time frame certainly changes. My general is probably to follow them annually, especially in younger patients for the first 5 years or so. At that point, I have a conversation with the patient to extend to 18 to 24 months. And then after 1 or 2 scans, if things are stable or minimally changed, I might go to 24 months after that, 8 to 7 to 10 year time frame or so. But I agree with Mark. I don't, especially in a younger population, I don't stop screening these. I will follow them much more longitudinally. It's very hard to have the 55-year-old woman who, or even younger, who has, you've told them what they've got and they've got 2 kids, or the 60-year-old who has their first grandchild and wants them to see graduate from high school, whatever, right? I mean, they have a much different time frame and anxiety level about not following these more longitudinally and or acting earlier, right? That's the talking them off the ledge that Gavitt mentioned earlier, that really can be challenging conversations that, yes, we may have to do something at some point in time, but now is probably not the time, and follow that with the surveillance path that, whatever works for that patient in their scenario.
I agree completely with what has been said. My, quick answer to this would be I scan them annually forever. And then the exceptions to that I would make would be when they get to a point that they're no longer going to pursue treatment, I would stop scanning. And also then for the younger patients, I start thinking about stretching out the intervals after you've documented stability. But I think the point is, and we were just talking about this, you're not even watching for this nodule. You're watching for other things that may come up. So the downside of starting to stretch out your intervals is what you're really looking for with these, like now it's a screening scan, is a faster growing cancer where you may not want to go to up to 2 years between scans, because the whole point is to catch something more life-threatening or more invasive and malignant. So the goal would be to get to where our scans are low dose and we're able to kind of just do quick annual check-ins on these patients. But I think it's hard for me to say, oh, you're done, you're clear, no follow-up needed. And I wouldn't tell that to anybody with one of these.
Great discussion. And I will just put in a brief little plug for my co-moderator, Yeon. She's going to be presenting some of her work out of South Korea, using some of the data, national database data from South Korea on long-term follow-up of subsolid nodules at the 2025 ATS International Conference in San Francisco next month. So just wanted to advertise that briefly. She has a podium talk coming up. But we are within the last 10 minutes now of our discussion, and we've kind of alluded to this question as well, but it's something that Gavitt brought up earlier that I'm really curious to pick everyone's brains about, which is this concept of, traditionally, if you have, let's say, a spiculated pulmonary nodule or like a mass or something, I think most of us would agree that preoperative staging, minimally invasive staging, oftentimes with EBUS or some other modality is indicated. But I think Gab was the one who mentioned earlier that for particularly these types of situations with either one or many subsolid nodules, she would not actually necessarily recommend doing that. And I think Andy mentioned the same. So I guess my question is that the consensus that among patients with subsolid nodules that preoperative lymph node staging is not necessary, and or PET CT as well would be kind of, I would group that in the same kind of category as far as looking for metastatic disease. And then this follow-up question is, this is, I guess, mainly for Gavitt, but among patients that you are taking to surgery, are you then doing intraoperative nodal interrogation as well, just to confirm that this is indeed, N0 disease? And for this one, I think we should start with Gavitt.
All right, thanks. Yeah, so I don't do EBUS, I don't do biopsies in advance in these unless I have to kind of convince the patient. And I don't do PETs because it's not changing my management. And there's nothing that imaging is going to show, positive or negative, that I think would really change it. I think the likelihood that the PET just sends you off on a wild goose chase of some PET positive thing is more likely than actual, picking up some nodal disease that's not evident by like a CT enlarged node. And so then in the OR, I do a full lymph node dissection. I do this for several reasons. I mean, one, you should just do this on everybody. It's kind of part of the case a lot of times. I don't think, just a wedge with no nodes, that's not appropriate. It doesn't meet our Commission on Cancer guidelines for what we're supposed to be doing, because the problem that we then encounter is that on your pathology report, this is going to be called a lung cancer. And so then you need to have done your nodal dissection. So every patient is getting a complete lymph node dissection, just as if they had a solid invasive lung cancer.
Yeah, I think radiographically, so few of these patients, both, as you mentioned, Gavitt, by CT and PET, there's really no characteristics that would say this is malignant disease is going to change what we're going to do up front in terms of EBUS. But as you said, and this was unfortunately just 6 weeks ago or so, a patient of mine that had surgery, had a segmentectomy done and had N1 and N2 disease. So it exists, it happens. Yeah. Thank goodness it's very rare, but it happens. And had we done EBUS and that patient ahead of time, would we have detected it? I don't know. We would have, right? It was clearly a micrometastatic disease. Would a needle aspiration of a 5 millimeter lymph node been able to detect that? I don't know. Maybe not. Had it, sure, it would have changed. There probably would have been neoadjuvant, right? Therapy, surgery, and so on. But I think up front, that number is so low. I don't think it's worth putting all these patients through nodal interrogation, as I mentioned before, also biopsying the primary lesion. So it's very different, obviously. I think we would all agree PET scan shows nodal involvement. You're going to do the nodal interrogation ahead of time, but that's incredibly rare, almost unheard of in these lesions.
Yeah, I don't have anything to add to all of that.
Yeah, I mean, just to play, I guess, devil's advocate for that, some might say, if you're doing the nodal interrogation anyways, intraoperatively, maybe should these patients have gotten, the EBUS staging procedure ahead of time, regardless. But certainly to Andy's point, understanding that when we do, transbronchial needle aspiration, we're only getting a tiny amount of, comparatively speaking, a very tiny amount of cellularity, compared to, a surgical dissection. So, I think there was I forget which journal is published in, but there was a recent publication that actually kind of said exactly what everyone on the call has been saying, which is that the likelihood of nodal disease in a radiographically negative mediastinum in someone with either single or multiple subsolid nodules is very low, but does happen. And I think Andy would know a little bit better than I. At our institution here at Penn, there is a little bit of variability even within our own institution regarding whether or not various surgeons or some of our colleagues perform in EBUS prior to potential definitive treatment for subsolid nodules. So I think it definitely is for sure still kind of up in the air, and I think guidelines don't necessarily differentiate that as far as my knowledge goes, as far as differentiating between if the primary is a subsolid lesion versus a solid lesion with regard to lymph node staging. For example, the NCCN guidelines, I think, with the most, at least as of September of last year, recommended to consider EBUS lymph node staging for any size peripheral tumor, even a stage 1A, but of course does not necessarily specify what the density of that lesion might look like. But Soyeon, sorry, Andy, were you gonna?
Yeah, I was just gonna make one comment. If you look historically, this is very old literature, by Dr. Korimoto in Japan. He was a thoracic surgeon, one of the pioneers in endobronchial ultrasound. So he did a ultrasonographic surgical resection comparison, and in those nodes where they did not make the diagnosis by needle aspiration, all the micrometastatic disease was in the subcapsular area of the lymph node, probably because you can't angle, our needle does not have changing angulation. And so you can't get to that subcapsular area, which is probably where the early micrometastatic disease starts and then spreads obviously then throughout the lymph nodes. So in these tiny lymph nodes where it's probably just, if it's there, it's subcapsular, you're just not going to get it by EBUS. And so that's why I just don't think it's necessary. And for those surgeons in our institution that want that, I always ask, why? I'm probably not going to get you anything different. But anyway, we work as a team and do what is requested.
So I think we're almost at time, but we have time for just one last kind of I guess take-home message from each of our expert panelists. And the question's a simple one, which is, we talked about how much uncertainty there is right now with, and non-standardization, frankly, with regard to how to manage these, how to follow these, how to even treat these sometimes. So I guess the question for everyone is, what do you think are the most important research questions that still need to be answered, for patients with subsolid nodules? And for this one, I think we're up to starting with Mark to get us started off.
Sure. Well, I think we'll actually get back to the previous question that I was answering, which was about how long to surveil these. And I think I agree with everyone that we're probably not going to stop surveilling them. So maybe the question isn't how long, but exactly how to do this, particularly in the younger patients. How many, every what years? Every 1 year, every 2 years? There are certainly screening protocols in other countries that are exploring every 2-year screening. So that might kind of fit in with also looking for other lesions. Is MRI a possibility in younger patients? It's not there now, certainly not in the community and even not at most academic centers. But ideally, because some of these patients are younger, ideally we can avoid the radiation entirely. So I think those are some questions that we really want to answer going forward, because I think most people now know what to do with the nodules once they start changing. And I think the real question is what to do with them before they have changed.
I think I like the answer of kind of just improved biomarkers for which are more concerning nodules than others. And can we identify this at a much earlier stage with enough confidence that you could kind of treat someone a little bit differently? And I think when you think about the categories of biomarkers that you're going to get, it'll be blood-based, it would be biopsy-based, or it'd be radiomics. And those all have their challenges. The blood-based one doesn't help if you're talking about multiple nodules, then you've confounded which nodule you're talking about. The biopsy-based, you miss the lesion, you biopsy the wrong portion. How do you know you got what was meaningful? But maybe you could get some sort of driver mutation or in the future, other data off of that. And then radiomics, you think with AI, maybe the imaging evolves in a way that we're able to predict better, or some sort of injectable tracer that, you could image to highlight maybe nodules that are more concerning than others. But I think that we'd love to have great biomarkers for how to identify more concerning nodules than others.
I would say the exact same thing. I reflected earlier in the talk too. So, I think that would allow us to really advise these patients in a much more logical fashion than what we do now. I think we just really don't do it. And I think if I could, my last words of advice, especially to my interventional pulmonary colleagues or those doing advanced diagnostic bronchoscopy, I think the most important thing we need to do is show restraint. I think the vast majority of these do not need to be biopsied. And I think, again, I'm probably the pariah of the technology companies. I think while this technology may help, you still need to think about whether the information, one, are you going to get the information? And two, what are you going to do with that information at the time that you get it? And for most of the very small pulmonary ground glass opacities that are there, they in my opinion, don't need to be biopsied, should just be followed. And that's a lot of what's being pushed in our realm right now to try to biopsy these. And I think that's the wrong approach.
Well, thank you everyone so much for joining for this hour. And we are at the top of the hour. And thank you so much again to all of our expert panelists. And thank you so much for everyone who joined for this lively discussion. And as a reminder, this will be posted onto the ATS website and onto the new YouTube channel, I think in just a couple days or a couple weeks. So thank you again, everyone, for your time, and have a nice evening.
Thank you.
Thank you.
Thanks,
Great
Roger.
discussion.
It's been a pleasure.